Yes. Using this solution, I will explain in detail how Dr. Park recovered the patient's vertical dimension and occlusion plane through both provisional and final restoration. Yes, so yeah, it's basic way. As a patient changed to edentulous, when bone resorption occurs, the patient BD and also patient facial appearance also affected. This kind of case have so many limitations. So as you can see in the morning, the patient bone condition is not good, such as very thin niche in anterior area and defect in the molar area. As Dr. Pa told you, using RE and BDC, we can solve this kind of limitation, right? So now, what should be to next? Attention to next. So I think it's Oronex prosthesis, right? So we did hands-on, right? You guys do place the Oron 6 and Oron 5 implant. And what is the most important for we set up the prosthesis? I think first one is the midline. Then second one is the position of incisor position, right? Incisor, central incisor. Then smile line for the anterior height and anterior position and size. We need a smile line. And then, especially if your case is edentulous at that time, we need vertical dimension and also occlusion plate. If we have these 5 information and send it to your lab technician or laboratory, they can easily make crown, right? Ideal crown. So if you guys didn't give to information, they have this kind of problem. This 3 picture is same patient, same photo actually. I just make an angulate, tilted. So this you guys think which one is correct? First one, second one, and third one. I always think about second one is correct. That's why this technician make a crown like this. This technician is not stupid because it's me. Almost 10 years ago, I designed this temporary crown. So I just guess because at the time, I just get stone models. So I just guess here is the incisor papilla here and humeral notch here. So maybe midline is here. And I just choose arbitrary some reference. Then I design crown, something like that. Okay, good. Looks very nice. But original is different. Third one is correct. That's why, I'm stupid. Yes. So it's only 4 unit bridge crown. It's only 4 unit bridge crown. What about edentulous case? It has so many complicated things. So usually, how to start for edentulous case? Maybe many of you using the wax bite or wax frame, or if you have a 3D printer or digital export for the specially edentulous, you can make a copy denture, scan the denture and print out. And edentulous case, if we need some condylar position for the vertical dimension or hinge axis, if you need more good occlusion, at that time we have to do baseboard transfer like this. But normally, we're using the wax bite way. But it's simple because we do a lot of job, but actually behind this, it is not simple. It's so many processes in here. For example, you guys have to scan or take impression and send it to your lab, and your lab technician, someone have to make wax rim, and patient have to visit once again your clinic, and you need some adjustment you need some drawing the midline, drawing the smile line. You have to do jaw relationship, everything. And then, if everything is perfect, after that, you set up the old thing, and your lab technician make a temporary crown based on your wax rim. You need one more adaptation because everything is perfect, but that have so many tolerance. So like this. If we using this, we can skip this one. Yes. This machine R2 Studio Q or R2 Studio, we have a 3 function. First, large FOV CBCT. Then we can scan impression scan also, and also include facial scan. So using this one, through this one, we can make this one. We call it dental avatar. So facial scan, large FOV CBCT, STL, yes, we merging all together. So that means we can see where is the midline. We can see where is the smile line. And also we can design on the STL file. And also we can see the bone structure, everything, bone density. If we want to place the implant, yes, why not? That's the dental avatar. So usually your patient, when first time visit your clinic, start to final delivery, normally 8 times have to visit your clinic. So consultation, data collection, surgery, second operation, something like that. So we want to make a more minimal investment. So this one, we can skip 1 time. If your patient agree, directly we just scan with the CBCT and facial. Within 10 minutes, we can get all data. So, and I will explain how to use dental avatar. Why we have to using dental avatar? Because we have to share about, you guys have to share about 5 information to your technician. So for example, like this is, almost 5 years ago, I do this case. At the time, I do implant planning. So this doctor sent me, it's not Dr. Park's case actually. This dental staff sent me the scan data first, upper and lower and occlusal. And she say my dentist ordered to write this, all extraction upper and lower. Then place the old crown with the implant. We want to do oral neck surgery. So, okay, so how our tooth position? Do you have any information? I asked her. She say, midline is something wrong. Okay, I see. And overjet is something wrong. Okay, I see. And occlusal plan is wrong. We have to change everything. Okay, I know. How? This is my question. So after that, I asked her once again, like this. I know you're a dentist. He have an orange plan, treatment plan. Please give me more detail. After that, I get this information. This dentist wanted to share about his information to me, right? Actually, it's not finished. Actually, under here is the finish. It's very detailed. So I like it. So I see the old world and open the CAD software. I started to design. So I see design. After that, I cannot finish because some word I cannot understand. Something like this. This one. Number 8, is number 11. It's 2 millimeter longer. Too long. And number 9 is 3 millimeter long. Okay, so I think this scan data is same level of incisor. So this doctor wanted to make like this. Like this. So I cannot understand. That means I cannot design. So fortunately, he have a R2 Studio. So I asked once again, if you give me the large FOV CBCT with the facial scan, I can make a dental avatar. After that, I will make a digital ideal waxer, full waxer. Can you make it? So he said, of course, why not? Just take CBCT and facial scan. After that, when I make dental avatar, I fully understand. You see? Yes, that's why midline is something wrong. Here's the midline. Then, yes, anterior tooth will be tilted. That's why number 11 is 2 millimeter longer. Number 21, 3 millimeter longer. I got it. After that, I understand the treatment plan. That means I can design very easily. And I design is actually dental avatar. So inside facial scan, I already merging with the CBCT data. Then, yes, I can drawing the occlusion plan based on the FH plane. Then our occlusion plane shape is like this. So diagnosis wax up, I follow to diagnosis wax up with the occlusion plate. And as you can see, here is the functional cusp tip here. So that means it is ideal tooth position. After that, I just place the implant. Something blue diamond, something enriched, whatever. I see the bone, I know the crown position, everything is easy way. So yes, it is starting to the QVD solution. So I will explain more detail with the clinical case. So like this, after surgery, for the passive pit prosthesis, it is ideal to collect data with the position of the fixture and abutment already determined. However, it is difficult to control the vertical dimension, right? After surgery, there is so many bleeding and patient pain, something. So using that one, it is very hard to check the vertical dimension and anterior position, something. But using the dental avatar, we can easy to solve this. Let's see the clinical case. First one, this case, you guys already see this case, right? Are you guys remember, right? Yes. So, Dr. Park do the oral 5 surgery like this using the AXA. Then I make a denture because first we do surgery, lower first. So based on the upper denture, we have to make a prosthesis. So I just make a like this kind of marker in the denture, and with the denture, I make a dental avatar. And yes, this CBCT size is not enough. Only this CBCT, we know where's the midline. We don't know where's the midline, where's the smile line. So if you guys using the large FOV CBCT, you can see the many information, such as patient bone structure, shape, and where is the FH plane, where is the midline, soft tissue, and hard tissue, everything. Then I just merging with the STL and facial. I make a dental avatar like this. Then here's the FH plane, right? So after that, I using the AI, I just make a reorientation. That means like this. If you using the small FOV CBCT, you don't know where is the exactly good position. But we using the large FOV CBCT, that means we can see the many information. For example, orbitale to orbitale, or hinge, or porion. That means based on this reference, we can make reorientation for the patient head posture. So using the AI, automatically found 2 orbitale and one porion, and using this line, we just make reorientated. After that, we can draw in the midline, facial, smile line, everything. The other one is this one. It is, yes, as I told you, it is large FOV CBCT. Then using same algorithm, using same AI algorithm, automatically detecting the 11 point, and using that 11 point, we can do 3D separometrics automatically. And based on this data, you guys can analysis with the VD and occlusal plane and anterior tooth position, everything. So let's see. In this case, yes, I make using AI, I just make like this. Actually, I don't want to so many number. I just focus on the two things for the VD, y-axis. It is from the FH plane to this line. From this line, we call it is y-axis. So usually Asian people, y-axis value is 58 to 62. So I can choose the average in this number, and automatically it is setting the number, y-axis of 59. Then the other one is this one, upper incisor position. Based on it's same, based on the FH plane to N9, we can discuss about this tooth is correct or not, is too prone or not. So using the smile crater, using the AI, we already setting with the crown position, and also using the separometrics with the AI, we can analysis, is it correct or not. So we do double check. Then if this number is not enough, at that time, we have to open the vertical dimension, right? So how do you think? If you want a 2 millimeter open the mouth, maybe you guys have some experience to the order. Lab technician, can you make this patient 2 millimeter open the bite? At that time, do you know how to make it open? So just for example, open vertically. If vertically open 2 millimeter, that is not correct. Based on the hinge axis here, we have to open like this, right? So also we can found hinge axis because we can see the hinge, where is the hinge, where is condyle. So based on this point, we can open the bite. Then yes, after that we set up the VD. Then we can setting with the occlusal plate. The shape is like this. It is not flat. It is like this shape. So include curve of Spee and curve of Wilson. So based on this, and when you choose the tooth shape, avoid square tapering, it automatically attach this occlusal plane. So that means using the AI, yes, of course, it needs some changes. It's case by case. It's not perfect. It's only ideal crown position. We have to change with the patient mouth. But anyway, using just some click with the AI, we can make a diagonal waxum ideally. Then through this, you can control the something, and you can make a full waxum. Then I will show you the simulation. Yes, dental avatar. First, yes, I'm merging CBCT and STL and facial scan. That means I already make a dental avatar like this. Then, as you can see, this curve is not correct position, right? Two orbital lab is different levels. Also Porion, different level. So that's why this patient facial is some tilted like this. So click the AI reorientation, automatically make a correct position. Now, same level of the orbital leg. Also, AI detecting some reference point. Then, automatically calculate the number. After that, I load to lower STL file. And here is the hinge axis. Then I can load the occlusion plate like this. After that, if you want to change the VD, yes, of course, when you click the Q button here, it's automatically change the vertical dimension based on this hinge axis, like this. And if you want to make a bigger or lower, yes, why not? Then, after setting everything, after determining everything, yeah, we can easy to make a diagnosis waxer. Just click the lower full arch, and you can choose whatever you want with the patient arch shape. Then, if you click it, it automatically make a diagnosis waxer with the occlusal plate, like this. And yeah, if you want to make it more smaller, bigger, and change the position, yes, whatever. Yes, after that, yes, we just check with the facial scan. It's before. Yeah, actually it's after surgery. Then we evaluation the wax drop. Then send it to lab technician. They make a crown with this occlusal plate. It's very simple. Here is the mid-sagittal plane here, and curve of Spee and Wilson here. Just loading to library crown and just positioning the crown. That's all. Like this. Then it's temporary. Just temporary with the screw. Yeah, metal free, and we only do the 3D printing. Because of this, we make a very special crown screw like this. So it's not straight screw, it's straight and tapered here. So using this one, we can retention to the temporary or final restoration. Yes, it's temporary, more, once again. Then, like this. It's after surgery, we place the diagonal waxer. Then, it's temporary facial photo, like this. So, this one, without any wax ring, without some device, we just make a dental avatar. And we can determine the vertical dimension like this, and midline, and smile line, and occlusal plane like this. Yes. Then, after that, I just want to check with the temporary. The number is same as before and after. Yes, of course, it's almost same. Then, case 2. A similar case, yes, it's lower jaw. Yeah, as you can see, there is so thin niche bone here. So Dr. Park do the oral 6 surgery. It's same as today's hands-on case, right? Then 2 tilted implant and 4 straight implant with the AXA. Then Dr. Park ordered to me, can you make a QBD? Yes, of course, why not? After surgery, I take a large PVCVT and facial, and then make a dental avatar first. Then, yes, AI reorientation. Here's the approach plan. Yeah. According to two orbital and orbital limb, I can make, yeah, AI can make reorientated. After that, I want to do, yeah, I want to check with the dental avatar. At the time, yeah, I can see the something like this. Dental avatar include CBCT and facial scan. So I have to decide hard bone midline and soft bone midline. I can see the both. So at that time, I choose, yes, soft bone midline. But anyway, I can do double check with the midline, hard bone and soft bone. Then it's same way QVD. Yeah, using the AI, the AI can make find 11 points, and based on this, yes, I can make open the vertical dimension. If you wanna, yeah, 3 millimeter, 2 millimeter, based on the y-axis, we can make it. Based on the, yeah, condylar hinge axis. Then occlusal plate. The same way, I choose, yes, like this. Then, if you want to change the occlusal plate, the angle, yes, of course, why not? Like this. Then it's temporary with the occlusal plane. Then like this. Yes, it's same thing. Without any device, we can make like this kind of, yeah, prosthesis. And yeah, after surgery and after temporary, you can see the, yeah, before and after. Yeah, it's quite good. And number 3 case, yes, clinical case 3 is this. Yes, it's more complicated case, but same way, Dr. Park do the surgery. Then, yeah, actually it is, yeah, almost first time at the time when we make this case, at the time we just trying to QVD, and Dr. Park wanted to make this kind of solution. Without wax rim, we want to make a VD with the software. Okay, and at the time I have so many thinking, because I need some matching with the STL and CBCT. I need some landmark, but it is edentulous, so how to merging something like that. So I using the radiopaque tray. But yeah, this radiopaque tray is very nice, because all marker can make a merging like this. Almost I can merging perfectly. And if I reverse this impression, it is scan data, same as scan data. But there is something problem, because the condylar head position is something wrong, because of the tray is too larger, right? So anyway, I just make a dental avatar with this upper, lower merging, and facial scan merging, everything. So at the time, I'm very happy, because merging is perfect. And I do reorientation with the AI. After that, I noticed about the condyle position, right? Yeah, reorientation and condylar head position will be out of fossa. So I have so many thinking. I have to call once again for the take CBCT, or how to solve this problem. If I call patient once again, it is not minimum investment. It is same protocol as make a wax ring. So just in my opinion, if this is a condylar head position. If I make condylar head position to make here, after that, I can control the VD with the condyle hinge axis. And if I make a temporary, even that temporary is not perfect, but anyway, it is starting point. So I just try to write this. Like this. Then it is uppercase, so I need some anterior tooth position. With the AI, is automatically found the midline and alar to alar point, and this point should be the canine to canine. It's size of the tooth. Then it is not 2D, it's 3D, so I can see the occlusal view with the library. And based on this, I can calculate with the QVD analysis. Then I check the y-axis and I control the y-axis hinge axis from here, and I can adjustment here. Yes, of course, it's quite challenging. Actually, it's no option. At the time, I have no option. Only make a temporary crown, and adjustment temporary is option, I think. So I just make it like this. Then, fortunately, it's very nice. Yes, so I make a wax up like this. Yeah, something like this. It's temporary, so we can adjustment very easily. And if temporary is something wrong, at that time, we can change the temporary based on the first temporary. There is so many reference. For example, this temporary is too short, too long, or we need more adding anterior part, something like that. Okay, or we need some change the whole position. Yes, of course, we know where is the whole position. So our goal is anyway, we have to make a temporary crown, pastry, then after that, that is the starting point. Yes, upper temporary, like this. It's same concept of the screw hole, like this. Like this. Then clinical pole is upper jaw. Yeah, as you can see, this after that, Dr. Park asked to us. Yeah, now QVD is very correct, very good, very nice for me. So can you make within 2 hours something? So, okay, we try. So it is a live surgery case. So Dr. Park do the Oron 6 case. Oron, place a 6 implant within 1 hour. And after that, it's same. I just make a dental avatar like this. Within 10 minutes, I can make a dental avatar because it just takes CBCT and facial scan and intraoral scan or impression scan, whatever. Then matching is very simple. After that, AI can make a reorientation. I just waiting just 30 seconds. Then after that, I check the condyle every time. Yes, this case is quite a good position. So that means it's very easy case. Then smile analysis with the facial scan. Yes, here's the midline. Alar to alar position is, Actually, this case is, this patient have some little bit bigger nose tip, alar tip. So that's why the anterior tooth size is a little bit bigger, right? So I think at the time I have to reduce more the point, but anyway. And smile line here. Now I have all information. And let's do QVD. Based on the hinge axis, I can adjustment with the y-axis, something like that. Then occlusal plate and diagnostic wax up, and all data send it to our R&D guy, lab technician, and it's very simple. He have already know where is the midline, where's the speed and Wilson, everything. He just changed the crown position, drawing the crown position, and he just make a detail, then make like this, then using, this case is a live surgery case, so we cannot use, we don't have any option. We cannot mirror. Normally, per edentulous case, the milling time is over 2 or 3 hours. So we're using the 3D printer. And it's okay because nowadays 3D printer resin is very good. And also Oro-X case, especially per edentulous case, the thick is not thin, it's thick. So it is strong enough for arch. So that's why we choose 3D printer. And after almost 40 minutes, we get the crown, and using the glazing, we do like this. Maybe after finish this lecture, some of you, we make some crown with your upper this upper jaw surgery. So after that, you guys can check with the screw. Then, then you see, like this. Without any jaw relationship, any device, we don't use wax rim, we just take CBCT and facial scan. And using the AI and QVD software, we can make this kind of, midline something. Yes, of course, it's not perfect. Here's some gap here and something different. But anyway, after surgery, we can make a passive fit prosthesis for the especially aesthetic function. After that, after this provisional to change it to second provisional, it's very simple because we can use, because it is starting point. Like this. Then, I just check with the, so after surgery, smile analysis, it is almost within 2 hours, and within 3 hours, we can deliver the temporary. Like this. Then is, 1, 2, 3. This 4 case is like this. After surgery, you guys can do the QVD, using QVD, you can do the temporary crown. You can setting the temporary crown with the viable information. But some of you need to, before the surgery, if you guys wanted to place the implant planning, or you guys needed some guide, at that time also, we can use QVD solution. It is full sequence of the QVD solution. So if you do the full surgery without guide, you can do like this. Or if you guys need some guide surgery, or some case you need some diagnosis before the surgery, using this sequence. When patient first visit, you can take photo or X-ray, something like that. Then also take facial scan first. And using the facial scan, we have a software for the Smile Creator. It's automatically facial scan can change to the goal, show to the goal how to change, something like that. Automatically found something RR to RR and crown library here. And using this, you can discuss with your patient. So if you do the implant surgery, yes, we can make this kind of smile line, something like that. Using this solution, using this software, you can easy to get your get patient agree. If patient agree at the time, you just take CBCT. Just take CBCT and impression. Then every data is here. You don't need some wax rim, copy denture. You don't need some time. Just agree at that time, take CBCT and take impression or take intraoral scan. it's all full data for full arch. So using make a dental avatar, then AI reorientation. Yes, it's same. Yeah, you see the CBCT position is something wrong. AI can automatically adjustment to the correct head posture like this. And then, we make it like this, before and after. Then AI automatically found some 11 reference point, like this. You see, this patient have so many extrusion for molar part. So anyway, AI can find where is the occlusion plane. Yeah, of course, it's not perfect. We need a little bit adjustment. Yes. Then let's QVD. You see, this patient there is no stopper here. This is a original bite, upper and lower. There's no stopper. So that's why the y-axis is very lower, 54. So we just open the y-axis 49 according to hinge axis. Then open the vertical dimension like this. And also we can measure to vestibule to upper vestibule to lower vestibule. So we can check the vestibule to vestibule together. Then fix that point. Then this is our QVD analysis, the analogy from this article. Usually, I checked a lot of separometrics, some method, some analysis, but actually it is very difficult for me. So many reference and so many different things, but I want to make it simple. So I just need to 5 information: midline, smile line, incisor position, VD, and occlusion plane. So using the McNamara line, the McNamara line, he say, this analyst say the incisor position. Where is the incisor position? From the FH plane, from this N line. So using that one, and Downs analysis also, from the FH plane, where is the vertical dimension line, where is the occlusion plane line. So we just mixed these two things, and we do some practice with our patient, and we can check the y-axis. So after that, we setting this patient 59 y-axis, then place the occlusion plate from the FH plane to 10-degree occlusion plane. Then, based on this occlusion plate, we can design Waxer very simply. Then, you see, we can check with the dental avatar. Yes, she will change the height maybe like this. Then, before the surgery, of course. Now, I just merging everything, right? And I know where is the ideal tooth position. Then, I just choose the bone, where is the good bone with the crown. It's very simple way. And using the blue diamond or blue diamond cup, I can place the implant like this. Then, before the surgery, we can make a temporary also, because we know where is the implant position, and we know where is the gingiva, everything. So based on the occlusion plate, we can make a temporary crown like this. It just make detail from like this. Then this case needed to some bone reduction. Because because it's so many extrusion, the tooth here and also here, because there is no stopper. So at that time, we just try to stack over guide with the arch gate. Then, yeah, upper and lower, I just make like this. Then, when patient the second visit, we can do surgery. Yes, here is the reduction line. But nowadays we don't, we no need to reduction, right? But anyway, at the time we just try to reduction, with the stack over guide, something like this. And here is the magnetic, like this. We fix the base guide, and there are so many connector. I know that some cone shape or some post shape, but in my practice, I just want to something like that. If I drop some guide, it make a passive pit. It will be better. So that's why I choose the magnetic, and because we need to change the guide and sitting guide and implant placement guide, something like that. So anyway, I just make it like this, and Dr. Park do the surgery with the like this. Then upper, also same protocol with the guide, like this. Yes, here, extraction tooth, and change it to guide, stackable guide, and drilling here, and place the implant. Then he do surgery like this. So the upper is planning, lower is the real, X-ray, almost same, right? Then after that, patient doesn't want to do more treatment because upper and lower and little bit reduction for her is very hard day. So she want to next week wanted to make a temporary. So of course, why not? So we just after surgery we just scan it. Then using that VD solution, QVD solution, we just make a temporary like this. So same without any device, without any X-ray, we can found midline and dimension, height of VD, and everything we can do like this. Yes.
See that, because I have the same challenge. See that central incisor lingually?
Here.
It's a bit bulky, right?
Yeah.
Now, do you think if we used angulated AXA, would be the bulk less, or what do you think?
You mean if you want to choose something like this?
What do you prefer as a technician? Because again, if you go labial, I don't know, would that make the incisal edge weaker?
More vertically?
Because the axis will be close to the incisal edge? Or how would you solve this? Because the patient would come to me and say, it's too bulky, I don't like it. And I don't know what's the solution for this.
Okay. Let me check later with our technician. But how about this? I just say, if we make actually from here looks like very bulky because here is narrow. So if we make something like this, how about this? It will be. Yes, I think so. If over here is bulky because of tone, right? But this is narrow and this is bulky, that means patient feeling is bulky. So if we make something like this,
it will be. My other question is, how would you feel if we shave this and have, is there a minimum, do you have to have PMMA cover or zirconia covering the whole height? Or can it be beveled?
Sorry, can you say it once again? Yeah.
No, this is your AXA, right? Let's say. This way. Right.
Yes, yes.
Does the PMMA or the zirconia has to go all the way thick, or
Yes.
can it be more beveled to reduce the thickness?
No, all the way to be.
Yeah.
Yeah. Here. You mean here is the
Yeah. This is lingual buccal.
lingual buckle. And
So is there a minimum thickness you recommend around the axa?
you mean zirconia
Lingual.
thickness?
Zirconia.
Minimum thickness.
Yeah. What do you think?
Usually 1.8 for the screw, because that's what the screw is going to sit on to cinch it down. And so you,
Yeah,
like
because
we'll
the
usually
screw
set it
goes
at
all the way
1.8. Yeah. We want that much between the bottom of the screw head and the bottom of the.
So how would you usually?
We would do exactly what you said.
Just
We would
make it
thicken the
all
laterals,
bulky.
and
And
nobody
push them
seems
once
to
further
complain.
difference.
Yeah.
You wouldn't put an angulated one forward?
I think if you could, 10 degrees might make enough difference.
Yeah.
The other thing is depth. If you can go deeper,
To go deeper, that's the
you
thing.
have an easier start at that.
Yeah.
But I think this is always a challenge on FP1
Yeah.
when you've got splinted units, whether it's N-type or OXA. But I think that's been our experience is if we flatten that out, almost like a lingual veneer, where it
Push them
just
one
feels
side.
smooth, they're happy.
Yeah.
But I agree, that's always we're looking at that and thinking, oh man, that's the big mom.
Thank you very much. Yeah, yes. Okay, so after that, yeah, she changed the smile. Yeah, actually we don't have a before picture because she don't want to take picture with she's teeth. She's something wrong teeth. So, but after temporization, finally she can smile. So we can take photo like this. You see, it's not only for the function of teeth. When I meet her first time, looks like very skinny. But after temporization, just 2 months later, looks like very healthy. It's changed like this. As you can see, something like that. Then, yeah, final restoration. Actually, until QVD solution, it's finished. But your job is not finished because we have to deliver final restoration, right? So at that time, I just think about, still we developing this solution. But anyway, we know we using the large FOV CBCT. That means we know where is the condylar position, and if we tracking the condylar movement, like a protrusion, retrusion, if we tracking the condylar position, maybe we can make something like this. Right? So, actually, this score is me. Yes, so, yes, I think, it's quite similar from my bite, right? So, like this. If you see this, if some software say, it is some patient motion, something like that. Wow, wonderful. If there is done, it's nothing. So only see and done, finish. What? So what? So we have to transfer to this movement to CAD software, occlusal plate, right? So that's why we export all number, like a Bennett angle number and condylar angle number, condylar movement number, and CAD software have some value here. So we just write down here, then move like this, and using the CAD software, we can see the contact point. So if we reduce this, we can make a guide for the canine guidance or group function guidance. Using this, we can make it. We can get the patient occlusion like this. Then, after that, we can make a final delivery, something like that. So we just change the tooth shape because she say everything is good, but tooth is too scared. So can you make a more, circular? Yes, why not? Then like this. So using the QVD solution, we can reduce the consultation with the patient and data collection one time. And also we can make a surgery to delivery is one time. So normally from start to final delivery, patient have to visit 8 times, but using this one, we can make a half. Like this. So this one. Our goal is to, like this, minimum intervention, ProArch workflow. For the bone resorption and thin niche bone defect, using the RE and BDC, we can cover this. We can make a reduce your time. Then the other one is the before adaptation. That means wax remote adaptation. Then data transfer. That means we have to wax rim is not 3D data, so they have to make a 3D data scanning, something like that. Then even you do the good jaw relationship, and if you guys have to very good drawing of the midline on the wax. Anyway, after temporary, you need some adaptation, occlusion, and bite, everything. So we want to make a reduce this part. Using the QVD, we can do it, right? Then, final delivery. We need to, until temporary. If that has some error, we can easy to fix it. We can trim, or we can edit, or we can restart, something like that. But final delivery is different. We need more accurate, right? So at that time, we using this solution. We have a 3 data collection like this, digitalization for this. First one, using reverse scan body. Maybe you guys already know how to work, right? So after apply to all the temporary, and using temporary, we just screw tightening with the reverse scan body here, and take pick up impression. Also, we screw tightening with the reverse scan body, and we merging all this part like this. So that means occlusion, temporary crown, contour, everything we can merging all together. Then just design the final delivery like this. And the other one is we want to make it more shorter. This one, we have to do scan and impression together. It's not good. So we check that we have so many research for the ProArch. There is so many scan bar in the world. For the ProArch, they say Oronex prosthesis, something have. So that's why we make a ProArch scan bar. We can use 2 things. First one, crust tie. Maybe you guys know this concept, right? Intraoral scanner always have some learning curve, some distortion about here, this curve. So if we using the normal scan body that have so many distortion, so we cannot make a passive prosthesis. So using scanner, and it is almost same as FOV for the scanner. So one time we scan here, and after that, next time we scan the gingiva, we merging together. That means we can more correcting implant position. Then the other option is like this. It's more simple way. We just scan like this. So in dental case, there's no structure, so we cannot scan very easily. So we just make a structure like crown. So we just scan it like this or like this. Then, so, so if you have you guys already have a scanner, right? So if you getting this kit, you can start to pull arch with the AXA. The shape is like this. Yeah, there's the good library merging point here. Yes, and here we do some character. That means we can easy to scan here, and yeah, like this. Here is the prevent pressure on gum, like this. Then using this one, you can make this kind of prosthesis. Then next one is if you want to more accurate, yes, something, if you want to make a metal bar with the crown, bar bridge, or that means at that time you need more very accurate, less than 20 micrometer something. At that time, yeah, this kind of prosthesis, yeah, here's the bar bridge, like timber type, and with the crown. At that time, this bar bridge, the passive pit is very needed to accurate. At that time, if you have so many full arch case, at that time, you guys can using the photogrammetry. Yeah, it's very new. I think, yeah, still we developing need a little bit more. End of this year or next January, we can release this. Let's see just like this. Oron, 6. Just take figure impression. Almost 50 seconds. We can get in the abutment position. Yeah, we call this altimetry. So after that, yes, we can do prosthesis like this. Yes, so almost done. So please remember this one, minimum intervention. For the full arch, yeah, we're using the BD and RE. Then R2QVD. Yeah, if you make a temporary, very fast, very easily, after that, your full mouth will be very simple, right? You guys agree? Please agree. Yes, thank you. It's done. Thank you. Thank you very much.